I'm a GP in east of London, and I'm also a GP trainer. So I welcome you on behalf of IMI UK today on this educational webinar, which is part of our series. We're very much thankful to Al Sadiq International Virtual University, who are our collaborator for this webinar. And they've been running these sort of educational webinars for the last 5 years. And we've just been listening to all of the incredible work that they've been doing. And it's a pleasure that they've provided us this platform where we'll be hosting one of our first of our series of educational webinars. IMIG UK, most of you would be aware of the organization, but just to give you like a brief outline of what we are doing at the moment in the UK. Basically, IMI UK provides a platform to all of the healthcare professionals and allied health professionals to come together, network, and plan and deliver projects which are for the betterment of our community. So at the moment, we are focusing on educational programs. We've got loads of like community-based programs running. We've been doing, things about disaster management, and there's loads more that is available. And if you're not already a member, please do come and join us at IMI UK. Our seventh president, Dr. Vajili Khwaja, he's been an asset and has been very helpful in building up the board of members, which we all are, myself and Dr. Aijaz Haider. And under his guidance, we've been running multiple projects and have been learning a lot. So please do join us at IMI UK. Now, just to give you a brief introduction about Dr. Aijaz Haider, most of you already know he's such a big name in the IMI, especially in IMI UK. Also, he's a GP in Dunstable, north of London. He's a GP partner there, and his passion is about teaching medical students. Dementia and frailty is one of his specialities. And he's been born and brought up in Berlin, Germany, where he completed all of his medical education. And he has moved to UK now, and he's been serving people here. And Dr. Aijaz had played a pivotal role in building up IMI Germany and Austria, and he's current European coordinator for IMI. So before we start the presentation, I would just suggest just some sort of ground rules. Please keep yourself muted. Your camera you can turn on if you need to, and make sure you're on mute during the presentation. If you have any questions, we will take it at the end of the presentation. You can start posting your questions if you'd like using the chat option. There's a chat option. You can post your questions there, and we'll keep that monitored. If you have any sort of technical issues during the webinar, please post your message in the chat, and we'll keep an eye out for that. And we'll take questions at the end. So I'll hand it over to Dr. Aijaz, who's going to be talking about dementia and frailty, which is a very common topic that we normally see as healthcare professionals. Obviously, even as somebody who's not related to health, we all would have come across a patient suffering with dementia, and it's such a big life-changing diagnosis, not only just for the patient but also for the family. So let's hear it from Dr. Aijaz. I'll hand it over to you.
Yeah. Thank you very much, Ashba, for the kind words and the nice introduction. And also thank you to Dr. Shabizadi and Sivu and IMI for giving me the chance to share a little bit of my experience. So let me first of all share the slides. 1 second. Okay. So as Ashba said, I'm not a kind of a psychiatrist or a memory clinic specialist, but a GP. So I will be kind of talking about dementia from a primary care and general practice kind of point of view. It's a huge topic. We can talk the whole day about dementia, so I will be concentrating on a few things. So a bit of a kind of historical introduction. We'll talk about shortly about the different types of dementia, then risk factors, and lucky for me, in 2024, the Lancet, which is one of the biggest medical journals, convened an expert commission for the third time and published the Lancet Expert Commission dementia summary basically of evidence. And then in the end we will talk a little bit about kind of social aspects of dementia, particularly assessing mental capacity and kind of issues around that. Yeah, right. First of all, I would like you to ask a question. So in order to understand dementia, we have to understand the brain and particularly higher cognitive functions. So if you could use the chat and just kind of note down what comes into your mind when you think about higher cognitive function, higher brain functions. What is that? So we have got the kind of lower functions like motor functions, sensory functions, vision, hearing, but what would come to your mind when we talk about higher cognitive functions? If I can give you a few seconds, maybe 30 seconds to just write a few things into the chat with regards to that. Um, and then we will go back to the, yeah, memory we've got. Yeah, Asia. A few other thoughts. Yeah, exactly the analytical kind of aspect of thinking, analyzing things. Yeah. Creativity, I think that's very important in decision making. Um, I mean, some kind of low-level decision making you can see in other mammals as well, but not creative thinking, the ability to learn. Absolutely. So, yeah, very, very helpful. Cognitive function. So, a few kind of very, very, very essential points. So, there actually a lot of kind of things. So perception, for example, language, and that's kind of sensory as well as motor language. You know about the kind of areas in the parietal cortex, reading, writing, calculating, emotions. They're kind of created and processed in the higher cortex. Memory. With memory, there are different types. So short-term, long-term memory, semantic memory. And episodic memory. So semantic memory is basically if I hold this up, my brain tells me this is a book, but the episodic memory kind of relates my personal experience of having read the book, having enjoyed the book, when did I read the book, and what kind of I got out of that. So that's the difference between semantic and episodic memory. Then we've got mental time travel, so you can think back about what you have did, about what you have done in the past, and use that experience to forward plan for different kind of options and different circumstances. So plan A, B, and C, if you want to see it that way. Then we've got, oops, that's an empty bubble. Spirituality. Yeah, I think spirituality is also a function of higher cortex. Yeah, being subjective, being objective about observations, imagination. So that comes into play with creativity. Motivation. I think motivation can be an instinct, but you can also motivate yourself by thinking about it. So kind of getting motivated to do this webinar was certainly a higher cortical function rather than an instinct. Abstraction, I mean, mathematics is the, I think, one of the greatest abstract constructs of the human, of the collective human mind that you can imagine. So higher maths is just amazing. We have cognition, that's kind of thinking, recognition, recognizing things, and humans are the only kind of species who have metacognition. So metacognition is thinking about thinking. So how are we able to think? What are the mechanisms? What are the philosophical aspects of thinking? Can we know everything or can we just know a limited piece of the universe? What's the ultimate truth? Obviously, Allah Ta'ala, Islam, the knowledge of the nur of the Ahl al-Bayt, and how far can we kind of even imagine to approach it. Reflection, so we have an experience and then we reflect on that. And reflection can be individual and it can be collective as well. Very important, the awareness of your individual self. And that leads into social interaction. So as long as you're not aware of your individuality, of yourself, you can't be part of the of a group. You can't have interactions with a group. Behavior, that kind of is a result of your higher cognitive function, and then obviously consciousness as the basic. So there's a lot of kind of things that our kind of cerebral cortex does, and often without us actually consciously being aware of it. But and that again is a wonder of your of the brain. You can be conscious of all these things and think about it. Yeah. Quick anatomy. So you've got the brain, you've got the cerebellum, you've got the brainstem, and the main areas which are involved in kind of higher cortical function, thinking, memory formation is the frontal lobe, so thinking, behavior, and memory. Then new memory formation in the hippocampus, which is behind the temporal lobe, and learning and long-term memory in the temporal lobe. Parietal lobe, language processing. Right. If we look back into evolution and other mammal species, you can see that from mouse over cat and lion, polar bear, chimpanzee, bottlenose dolphins to the human brain, there's an increase in size and weight, but also an increase in complexity. So dolphins are actually pretty intelligent and social animals as well. So if you compare their kind of structure of the brain, it's much more complex than, for example, the brain of the African lion. So lions are probably a bit dumber than dolphins are. Okay, right. Next, well, if we look back, obviously we all know about Dr. Alois Alzheimer, who first described the pathophysiology of a specific type of dementia. But there are verses in the Quran which kind of allude to dementia, and I thought just to make that connection between our faith, because obviously the Quran is a vast source of knowledge. I could dig out some verses. So Surah Nahl, verse 70, and Allah has created you, and He takes you away to die, and of you is he who is reverted to the lowest stage of age, so that he knows nothing after having knowledge. So I think that's a cardinal issue with dementia, isn't it? Knowing nothing after having knowledge. So the deterioration of memory, cognition, etc. Surah Rum, verse 54. Allah it is who created you out of weakness and then caused strength after weakness. So as you grow, become adolescent, and then an adult, you grow in strength, then caused weakness after strength and gray hairs, which many of us have. So weakness after strength alludes to physical as well as mental weakness. Then Surah Hajj, verse 5. Then we bring you forth as babies, then foster you that you reach your maturity. And of you is he who is brought back to the feeblest stage of old age, and he knows nothing after knowing much. So again, the kind of decrease, the deterioration of mental capacities and knowledge. And finally, Surah Yasin, verse 68, and whomsoever we lengthen in age, um, we reverse him to an ancient state in life. So the ancient state means the state of kind of older age and kind of physical and mental decline. Now, not everyone who ages does decline in his mental abilities, and we will have a look at certain risk factors a little bit later. Yeah. Right, next slide. So looking at the golden age of Islamic science around the 10th till the 13th, 14th century common era, we have got Abu Bakr al-Razi, who lived in the kind of early 10th century. He was a kind of, well, in those times, you were not just a doctor, you were a polymath, you were a scientist, you were an astronomer, you were an alchemist or chemist, you were a philosopher, and you were a theologian. So he worked in Baghdad, and in his book, Al-Hawi fi al-Tib, he kind of tried to establish a concept of mental disorders, and he split mental disorders on to the basis of impaired thinking and perception, so things like psychotic illnesses, depression, and mental disorders involving loss of memory and cognitive decline. So that was kind of a bit of a structural step. And then famous Abu Ali ibn Sina, who lived around 100 years later, a Persian kind of medic, also active in different areas. He wrote his phenomenal kind of compendium Qanun fi al-Tib, which is known as Canon of Medicine, and has been used for 1,000 years up to kind of the early late 1800s hundreds as one of the essential medical textbooks, not just in the Middle East but also in Europe. He described this dementia as nesyan, an Arabic word which kind of encompasses dementia, and he kind of split it up in three different areas. Fisad al-zikr, which is he characterized with short-term memory loss, problems understanding, cognitive problems. Fisad al-fikr, which kind of presents itself with inappropriate behaviors, inability to describe what someone has seen or heard. So that would kind of fit very much with what we call pre prefrontal dementia. And then Fisad al-Takhayyul, which he describes as lack of dreaming and imaginations, having hallucinations, confabulation. So you can say probably dementia with Lewy bodies has got some of these features. In kind of Islamic thinking, Islamic philosophy, dreaming and dreams play a very big role in kind of Islamic mental health. Probably not as big a role, or that it doesn't play as big a role here in Western medicine as in our Islamic tib. Okay, right, next one. So at the bottom, I've just put the references. Fast forward to the late 19th, early 20th century, Dr. Alois Alzheimer was a psychiatrist initially in Frankfurt, then moved to Munich, and finally, in the last few years of his career, became dean of the psychiatry department at the University of Breslau, now in Poland. When he was working in well, it was called mental asylum or psychiatric inpatient unit, in the beginning of his career in Frankfurt, he came across Auguste Deter, the lady in the corner, who was a patient who displayed very much symptoms which later became to be defined in Alzheimer's disease. So Auguste Deter was a 51-year-old patient who was admitted for, well, I think 5 or 6 years to the mental hospital in Frankfurt, where she finally died. And Alois Alzheimer not only had access to her notes or directly to the patients, being able to observe her, speak to her. After the death, he had access to her corpse and to samples of the brain, which he then analyzed histologically. He published his he presented his finding on the 3rd of November 1906 at the meeting of the Southwest German Psychiatric Association in Tübingen, but due to politics he was ignored, and later then, 5 months later, he published it in the General Journal of Psychiatry and Forensic Psychiatry in Germany, which is on the left. I just wanted to take a minute to actually read his original kind of presentation, just the description of Auguste Deter, because it kind of shows you you will certainly recognize very typically symptoms of symptomatology of Alzheimer's dementia. So I quote, and this paper or the translation is available freely, and I've put it in the references at the end. So, on an unusual illness of the cerebral cortex, über eine eigenartige Erkrankung der Hirnrinde. A relates a case which had been observed in the insane asylum of Frankfurt am Main. The first symptom the 51-year-old woman showed was the idea that she was jealous of her husband. Suspicion. Soon she developed a rapid loss of memory. She was disorientated in her home, carried things from one place to another, and hid them. Sometimes she thought somebody was trying to kill her and started to cry loudly. In the institution, her behavior showed all the signs of complete helplessness. She's completely disorientated in time and space. Sometimes she says that she does not understand anything and that everything is strange to her. Sometimes she greets the attending physician like company and asks to be excused for not having completed the household chores. Sometimes she protests loudly that he intends to cut her, or she rebukes him vehemently with expressions which imply that she suspects him of dishonorable intentions. Then again, she is completely delirious, drags around her bedding, calls her husband and daughter, and seems to suffer from auditory hallucinations. Often she screams for many hours. So that kind of shows you a good descriptions of the different kind of symptoms. So the suspicion, paranoid thoughts, the loss of memory, the inability to do day-to-day kind of activities, helplessness, Also fluctuation in the behavior from kind of being nice and kind of relaxed to being aggressive, agitated, etc., etc. Yeah, so a very textbook description of dementia in generally. Now, with dementia, what are we looking at? Often we find that, oops, sorry. Often we find that kind of patients revert back into, sorry, let me just stop sharing for a second. Revert back to kind of like a almost infantile state of their life. Sorry, I hope you can see that again. So let me just, yeah. So dementia is not just a memory loss, it affects a whole range of brain function. It's a chronic and progressive illness, and there can be fluctuations in cognitive function. And dementia itself is a collection of symptoms, a syndrome, as we say, but it can be a result of a variety of diseases. So the WHO defines dementia as a syndrome. Syndrome is a collection of symptoms in which there's a deterioration in cognitive function beyond what might be expected from the usual consequences of biological aging. So it's more than just getting older and getting a bit forgetful. It could be described as brain failure because, yeah, particularly higher cognitive, higher cortical brain failure. Yeah, right. So different kind of areas. So there's the cognitive change, cognitive loss, inability to do complex tasks, short-term memory loss, loss of conversation, inability to write. These are very much symptoms. You see behavioral change, and we will come to different types of dementia where behavioral change is kind of present in different levels. So you get disinhibition, lack of motivation, lack of kind of withdrawal, aggressive and challenging behavior. You get psychological changes, which are mood changes. Very often it's associated with frustration, depression, anxiety, inappropriate emotions. That can be a hallmark as well. At later stages with advanced dementia, you will often get effects on mobility, so apraxia, not just the fact that people, for example, with advanced dementia don't know how to use a mobile phone, how to switch it on, how to type in things, but they're physically, the fine motor function suffers as well. And then later on, the gross motor function is affected, not able to walk, they become chair bound and ultimately bed bound. And finally, at advanced stages of dementia, urinary and bowel incontinence sets in as well. Okay, bit to epidemiology. So the case load or the incidence and prevalence of dementia has increased and is going to increase significantly. So if you look at worldwide data, currently there are around about 55 million cases across the globe. In 1990, there were roughly 20 million cases, and that's all estimates. And in 2050, we reckon there will be 139 million dementia cases. The worldwide cost of dementia, so not just the cost for the medical care, but also the cost particularly for social care. And you need to remember, in a lot of countries and in a lot of cases, it's the family members who take on that cost by caring for their loved ones. The cost in lost income for the economy, etc., worldwide was estimated at nearly 1 trillion, at 18 billion dollars. And most tragically, it shortens life expectancy and it shortens the quality of life as well. So that's just a little graph for the worldwide numbers. UK-wide, and there are dementia statistics available on the net by the Alzheimer's Society. There are nearly 1 million people with dementia living in the UK, and amongst them, 7%, round about 78,000, are people with young onset dementia under the age of 65. The number is projected to rise to 1.7 million by 2050, and dementia is the 7th leading cause of death in the United Kingdom. Okay. Okay, right. Next, right, types of dementia. So the majority of dementia is Alzheimer's dementia, 60% roundabout. Then we've got 15% vascular dementia, and these are UK numbers, not global numbers. You've got a mixed type of mixed or atypical dementia where you have features or pathological changes related to Alzheimer's, but also small vessel disease, vascular dementia. Then 10% are dementia with Lewy bodies, and we will come to the individual types of dementia in a second as well. Then we've got other dementias, 3%, and frontotemporal dementia, which is a dementia which tragically affects younger people to a big degree. Yeah, right. What's the consequences of dementia? Well, there had been a meta-analysis published in the BMJ, which actually looked at the consequences on mortality and nursing home admission. So they looked at, they kind of pulled together the data from 260 studies with a totality of 5.5 million participants, quite a large meta-analysis. They looked at mortality, and men always kind of have a worse mortality than women. So if you're a man and you're diagnosed with dementia at the age of 65, your average time or your average survival is 5.5 years. If you're diagnosed with dementia at the age of 85, obviously you're older, your average survival is 2 years and a couple of months. In women, they survive for longer, so the probably survival is probably kind of 75 to 100% longer. And if they looked at different types of dementia, people who were diagnosed with Alzheimer's disease had a slightly better or longer lifespan compared to people with other dementias. And that's across a range of ages at diagnosis. Yeah? So the later you were diagnosed, naturally, because you're older, the shorter time you had to live. And that's all compared to people who don't have dementia. Nursing home admissions, another kind of big factor. So if of all people who were kind of diagnosed with dementia, it took them around about 3.3 years on average to be admitted to a nursing home. Within the first year of diagnosis, 13% of all patients diagnosed with dementia were admitted to nursing home. And after 5 years, 57% ended up. Now, obviously, it depends on the stage when you're diagnosed. Some people, unfortunately, are diagnosed quite late after they have kind of developed a lot of symptoms, and some people are diagnosed quite early where they're still kind of quite well functioning in themselves. Yeah, right. Another meta-analysis looked at, that's a global meta-analysis, looked at mortality rates. And again, when they compared mortality rates, so the kind of chance of dying from in patients with dementia versus patients who don't have dementia, then there was a much higher risk or chance of dying for people with dementia. And that's kind of dying from any cause, so all cause death. So if you look at the graph on the left, they had a totality of 26 studies, and in these 26 pooled studies, they analyzed 7,500 patients with dementia and 80,000 without dementia. And patients with any type of dementia were 5.9 times as likely to die within, I think they looked at kind of 10 kind of 10-year span than people without dementia. And looking at the subtypes of dementia, particularly people with frontotemporal dementia had a higher chance of dying, 15 times as likely, and Lewy body dementia. Now, Lewy body dementia patients usually are a bit older than other patients, but they had a 18 times higher risk or chance of dying compared to a patient without dementia of the same age. Okay. Quickly about, and I will just whiz through the different types of dementia. You probably kind of know that from medical school and otherwise. So you've got Alzheimer's dementia, the type of dementia which Dr. Alzheimer described and analyzed. So what is the problem with Alzheimer's dementia? You have got the brain cells, and then you've got the nerve fibers which connect the brain cells, and they patients with Alzheimer's dementia form these plaques, amyloid plaques, in tau fibrils, which are protein deposits around the nerve sheets, which basically slows down and hinders the kind of electric communication of the nerve cells, and thereby kind of causes a slow degeneration. So Alzheimer's dementia, gradually progressive, no cure, and it's mainly cognitive and motor function which declines. The treatment, and we'll come to that in a later slide, is with something called cholinesterase esterase inhibitor. It doesn't cure it, it doesn't improve the stage of your mental decline, but it slows the mental decline down. Yeah. Then we've got vascular dementia, so that's got more to do, the kind of process in vascular dementia is more akin to what we get when you have coronary heart disease. So there is kind of furring of the vessels, arteriosclerosis, and that leads to kind of dementia symptoms. So it's basically what we call small vessel disease, or a series of mini strokes in the brain. It's a more stepwise deterioration, and the treatment is with really aggressive control of risk factors, which is kind of stop smoking, reduce your cholesterol, reduce your overweight, control your diabetes, antiplatelets, and statins. Yeah? Frontotemporal dementia, that's a type of dementia which affects the front and the temporal lobes, so the areas of the brain which kind of are associated with kind of thinking, behavior, etc. And it's a degenerative disease which affects younger patients, younger than 65 years. And it's kind of characterized very much by behavioral problems, disinhibition, but also speech problems. People are not able to kind of speak properly, gather their thoughts, they kind of babble. And unfortunately, it has got a very poor prognosis compared to even the other dementias. Yeah. You've got Lewy body dementia and dementia in Parkinson's disease, which are both very much related to each other. So again, older average age of onset, and Lewy body dementia has, when you look at the brain under the microscope, patients will have Lewy bodies, which are protein deposits around the nerve sheets, characterized very much by memory problems, sleep behavior disorder, so sleep disorder, and kind of the day-night kind of pattern is switched over. Often they have visual hallucinations, fluctuating attentions, and patients with Lewy body dementia often later on develop Parkinson's-like symptoms of tremor, discoordination of their limbs, stiffness in movement, and also Parkinson's-like symptoms like constipation and postural symptoms. Postural symptoms is when the blood pressure drops when you suddenly stand up from the chair or stand up from the bed. Some people kind of say that they're both the same thing, but with dementia and Parkinson's disease, you get the movement disorder or the motor problems before you develop the memory problems, and in Lewy body dementia, it's the other way around. Okay, but very similar kind of picture. Okay. Right, and then you have rarer forms of dementia, which are, I mean, as a general practitioner, I have come across people with dementia in alcohol abuse, Korsakoff and Wernicke syndrome, which then just aggravates. I have not really seen any people with dementia and HIV, Huntington's disease, or Creutzfeldt-Jakob. So Creutzfeldt-Jakob disease is a degenerative disease, a prion disease. You might remember the 1990s, where we had the mad cow disease, which was a type of motor degenerative disease which was rapidly progressive in animals, in cattle, which then lead to banning beef, etc. And the equivalent in humans is Creutzfeldt-Jakob disease, very poor prognosis, very progressive. Huntington's is again a degenerative neurological disease which is characterized by involuntary movements and again progresses very quickly. Dementia and Down syndrome, very, very interesting, because people who live with Down syndrome, they have kind of a lower ability of functioning and lower cognitive ability anyway. So how do you kind of discern if these patients have developed dementia? And it's common or not uncommon in people with who live with Down syndrome to develop dementia. So you basically look at their baseline, and if there is a sudden or within a short term deterioration in their functioning, in their mobility, continence, behavior, then obviously you would be suspicious and refer them to a more specialized service to have that assessment and diagnosis of dementia and Down syndrome. Yeah, I think amongst in our practice, we've probably got kind of 8 to 10 people who live with Down syndrome, and I think one of them is elderly and has developed dementia and Down syndrome a few years ago. Right. Risk factors. So what are the risks or what risk factors are there for dementia? And again, I would like to ask you to have a look in the chat and just 30 seconds and note down what you think are the main risk factors or any risk factors in dementia. Yeah, so I'll give you a few seconds while I sip my tea. Mm. Microplastics, very interesting. Yeah. Vascular disease, we have hyperglycemia or diabetes. Yeah. Genetic risk. Yeah. Very useful. Head injury. Yeah. Very interesting. So we'll kind of go through these risk factors in a moment. Yeah. And again, I would kind of refer to 2 bits of smoking. I would refer to 2 bits of literature. One is the Lancet Commission on dementia, and the second one, which I found quite useful, is where is it? It was a fact sheet from the Alzheimer's society, a fact sheet on risk factors. Okay, let me just go back to my slides then. 1 second. Share. Okay. Right. So yeah. So we've got non-modifiable risk factors, and the biggest risk factor in general, or the biggest non-modifiable risk factor, is age, unfortunately. If you look at the general population, at age 65, you have a 2% risk of developing dementia of all causes. And at age 90, you have a 33% risk of developing dementia during your lifetime. There are genetics, yes. I mean, it's kind of more, so with genetics, there are 2 things. One is what we call inherited diseases, so where you have a Mendelian trait of inheritance, autosomal dominant, autosomal recessive. So you can exactly say if your mom and dad had the disease, you have a 50% or 25% chance of getting the disease, etc., etc. And then there are kind of genetics where often multiple genes come together to increase the risk of a particular disease. So if you have a genetic predisposition, it doesn't mean you will get that disease, but it means you have a higher chance. So there's a gene called apolipoprotein E epsilon 4, and every person has got, as you know, 2 genes, one inherited from mom, one inherited from dad. So if you have got one of these genes, which is a particular type, ApoE epsilon 4, then by the age of 85, you have a 2 to 3 times increased risk of Alzheimer's dementia. So that's specific to Alzheimer. And if you have both copies of that gene as the ApoE epsilon 4 issue, so you're homozygote, then your risk by the age of 85 increases to 12 times the risk of the background population. Yeah? If you look at dementia population registers, you will always find, or in most countries, you will find that women are more likely to be affected by dementia of all causes compared to men. Now, the question is that a real association, or is that kind of confounded by things like women usually have a higher lifespan, they get older, and age is the biggest risk factor. And education probably plays a role as well. I mean, fortunately, nowadays in most countries or in a lot of countries, the level of education between girls and boys is kind of very equal. But those people who are now in their 70s, 80s, 90s, back in the 1940s, 50s, there was a lack of opportunities for women to be educated, and also a lack of opportunities to have kind of cognitively stimulating jobs. And we will come to the importance of education in a second as a risk factor. So these are non-modifiable risk factors. You're basically born with these risk factors. But there are lots of modifiable risk factors. So again, the Lancet Dementia Commission's working group did lots and lots of maths with the risk factors, came up with this beautiful graph or kind of picture. So they basically stratified risk factors in risk factors of early life, education, midlife, which is hearing, depression, physical inactivity, or the cardiovascular risk factors, and risk factors of late life, for example, social isolation and pollution. And through predictive kind of instruments, they kind of put percentages of how much each risk factor contributes to your risk of developing dementia. And basically 45%, sorry, 55% were these non-modifiable, but 45% of risk was potentially modifiable. Now, if you go to that in the next slide, so a lot of kind of good points were kind of put into the slide. So one risk factor, education. I wasn't aware of that much. So what does education do? Education increases your cognitive reserve. So physical, social, cognitive activities, very importantly, kind of school, high school, and then or also your job. If you have kind of a large cognitive reserve, then you will have more of a buffer before dementia symptoms become apparent. And studies have shown that higher educational attainment and high cognitive stimulation independently reduce the risk of dementia. So hazard ratio, risk ratio, odds ratio are kind of assessments of risks on risks reduction. So higher educational attainment compared to people who have lower educational attainment. People with higher attainment have a 73% risk compared to 100%, so 27% risk reduction. If you have a stimulating type of work with lots of creativity, different things, your risk is reduced by 20% to 0.8. And if you have both high kind of educational attainment, so whatever, high school, university, and a cognitive stimulation at work, then your risk is reduced by 37%. They've also looked at kind of things like computerized cognitive training later on in age, so online kind of things, and that really had little effect. And again, it comes down to the difference in the numbers of men and women. So earlier in this last century and up to the late last century, women really had a lack of opportunity in work and education. Then hearing loss, a very, very important factor. So having hearing loss in mid-age increases the risk of developing dementia by 1.28 to 2.5, so up to double the risk of developing dementia. And the severity of hearing loss, so how much decibel you lose in hearing, increases the risk as well. So per 10% decibel that you lose in your hearing, your risk of dementia, depending on the study, increases by 4 to 24%. And hearing aids actually reduce the risk of dementia by 20%, obviously, if hearing aids are given at the right time, early on. Vision plays a big role as well. So visual loss or visual impairment, be it due to cataracts, diabetic retinopathy, or other things, has a risk ratio of 1.47. So it increases the risk of dementia by 47%. Large UK Biobank study, so UK Biobank is a large cohort of patients who are followed up for really all different types of kind of analysis. They found that if you have untreated cataracts, your risk of dementia increases by 21%. Yeah. So hearing loss, visual loss, or obviously the factors which play a role. You have less input, less cognitive stimulation, and you also have kind of social isolation and withdrawal. So that's why these things are important. Yeah. Right. Yeah, these people look rather sad and uninvolved. So depression is another big factor. So depression works really both ways. So depression does increase the risk in dementia by more than doubling the risk. So the risk ratio between 2.25 to 2.65. And a large Danish case control study with a few 100,000 people actually showed that depression in early life has a higher risk, 3.08, compared to depression in midlife or late life. So a higher risk of contributing to dementia development. Yeah, but depression itself is a risk. And obviously, it's the other way around as well. Dementia itself can cause or contribute to anxiety, frustration, depression, etc. as well. And often you see in dementia that people benefit quite a bit from antidepressant treatment. Another social factor is not just being in jail, but social isolation. Yeah. So living alone, seeing family or friends less than monthly, no weekly group activity. Social isolation increases the risk of developing dementia in later life, and the risk or odds ratio is 1.57. So you have a 57% higher risk of developing dementia if you're socially isolated. What does social contact do? It builds your cognitive reserve through interaction, talking, socializing. It promotes healthier behaviors, it reduces stress, and social interventions have led to cognitive improvement and risk reduction. And I think that's why it's so important in our masajid, in our centers, to have kind of groups, activities, and the chance to intermingle for our elderly population, and also the chance to kind of interact across generations. So it's a very, very important aspect of our social life and our communities. Okay, so I'll rush through a little bit. Yeah, lifestyle and cardiovascular factors, obviously diabetes, midlife onset of diabetes increases dementia risk, and long illness, long duration, and poor control are substantial risk factors for dementia development as well. Very, very interesting. I mean, studies have shown that particular diabetes treatment, SGLT2 inhibitors, dapagliflozin, empagliflozin, DPP4 inhibitors like sitagliptin, linagliptin, and particularly the newer GLP-1 agonists, semaglutide, tirzepatide, they do have a protective effect in diabetes in the sense of protecting from dementia, additionally to their kind of diabetes control effect. So compare that with gliclazide. Gliclazide, which is an older anti-diabetic, has not shown to have that additional effect of protection from dementia in diabetes patients. Blood pressure, yeah, hypertension independently increases the risk of dementia, not just in vascular, but also for Alzheimer's dementia. So treatment of hypertension in two large meta-analyses reduced the risk of dementia by 7 and 13% respectively. And then a big factor, obviously, hypercholesterolemia. So looking at LDL cholesterol, which is the bad cholesterol, which stiffens your peripheral arteries and leads to arteriosclerosis, a large meta-analysis in UK showed that each 1 millimole per liter increase in LDL increases the dementia risk by 8%. So the LDL target, which is the bad cholesterol target, should be kind of in the general population below 3, and in high risk populations below 2. So if that increases, the dementia risk increases as well. Okay, this gentleman looks rather overweight, and being overweight is a risk factor for dementia. Now, it's not 100% clear if overweight itself or being overweight itself is a risk factor, or if it's the risks mediated by being overweight. Because if you're overweight, you do suffer, or you're more likely to suffer from high blood pressure, diabetes, high cholesterol as well. But even modest weight loss was associated with improvement in condition, in cognition, in kind of symptoms. Um, a large meta-analysis showed that being overweight increases the risk of dementia by 10%, but also being underweight, BMI below 18.5, increases your risk of dementia later on in life. Being active, sports, running, exercise, protective. Yeah, so physically active people are associated with better cognition at age 69 years anyway, and also later in age. And a large meta-analysis showed a reduction of the risk of dementia by 20%, so the risk ratio 0.8. And the strongest association was with sustained physical activities. Other lifestyle factors, of course, smoking increases the risk of dementia. Framingham, a large cohort study going on since I think the 70s in the UK, showed that smoking increases the risk of dementia by 42%, and the biobank study, UK biobank study, showed a risk increase of 70%. Alcohol, that's very interesting. And obviously, as Muslims, I don't need to tell you about alcohol, but high alcohol use versus light alcohol use increases the risk of dementia by 18 to 22%. And if you have episodes of loss of consciousness due to alcohol because you're totally done or because you fall, that in addition increases your risk of developing dementia because it leads to head injuries. Interestingly, mild alcohol consumption, in contrast to no alcohol consumption, has a mildly protective effect. But obviously, we know there are other kind of negative effects on other body systems of alcohol, so liver, kind of heart, cancer risks, etc., etc. So I'm not advocating drinking wine or anything like this. Yeah. Okay, then finally head injuries. I think someone mentioned it in the chat. Traumatic brain injuries. So be it falls, road traffic accidents, direct trauma, or repetitive trauma. Boxers and footballers who kind of do the heading, rugby players, and there have been, I think, a few very prominent faces in sports who developed dementia in later life. Because that can lead to longer term neurodegeneration, and several studies have confirmed a higher dementia risk with repetitive concussion, and a large meta-analysis showed a risk ratio of 1.6. Finally, and that's been a newer thing, pollution, air pollution. So air pollution definitely has a link with dementia, and it's especially particulate matter. So PM 2.5 are particulate matter, and they can be of all kinds. Usually it's kind of dust, black carbon, small matter from kind of combustion, etc. So PM 2.5, less than 2.5 micrometers, and PM 10s are less than 10 micrometers. The WHO target for particulate matter in air pollution is between 0 and 5. Just last evening, while I was preparing, I had a look at the PM 2.5 levels in Delhi, and they were, I think, around 120, 130. So, what is it? It's probably 25 times above the World Health Organization limit. So, 9 systematic reviews and meta-analysis, or meta-analysis with 9 kind of big papers, 91 million people, has shown an increased risk of 3%, or a 3% increase in the risk of developing dementia per 1 microgram per cubic meter PM 2.5 pollution. So if you look at New Delhi at the moment, PM 2.5 of 120, or let's make it easy, of 100, which is kind of 95 micrograms higher than the WHO's target. So you'll probably have a 300 times higher risk of dementia if you live in that environment for a long term. So not very good. Um, Nitrous oxide, nitrous dioxide, and ozone were not found to be significant risk factors. And studies from China have shown that reducing air pollution reduces dementia risk. Okay, so prevention, yes, I mean, there will invariably be questions of prevention. There's no kind of magic medication to prevent dementia, but a lot of things that you can do to to address the modifiable risk factors. So um, taking care of your health, stop smoking, reduce obesity, control your hypertension, control your cholesterol and diabetes, prevent head injury. Then you've got lifestyle interventions. Be physically active, exercise, minimize alcohol intake, prevent and treat depression, and also social aspects, isn't it? Address hearing loss and visual loss, increase social contact, be engaged, interactive, and kind of continue cognitive activity. And what that does is decreases vascular damage in the brain, reduces the kind of progression of neuropathology in the nerve cells, reduces stress and inflammation, and it builds your cognitive reserve. So start early, and you will reap the benefits later on in age, as is often the case with any chronic illness, right? Quickly, cognitive tests. How do you diagnose dementia? So dementia is, there's no kind of blood test as such, which is in widespread use to diagnose dementia. There are some biomarkers, and we will come to that, but basically the mainstay is looking at the clinical picture. There are certain cognitive tests, which are standardized tests and questionnaires. You might have come across them: 6-item cognitive impairment, GP-COG, mini mental state examination, MOCA. MOCA is famously the test which the current US president used, I think, in his first term, to say, oh, I'm very intelligent, but he didn't realize that it was actually a dementia test. So that time he didn't have dementia, luckily. So these are standardized, reproducible tests. Choose one or two to become familiar with and then use them. An easy test is ask the patient to draw a clock face, saying, put a clock face on the paper, saying whatever, 11:30, and then you can see, has he spaced out the numbers in irregular intervals? Has he numbered the kind of clock face properly? And has he put the dials of the hour and the minutes in the right place as well? Okay. Nowadays, kids don't learn to use analog clocks, so I don't know how long this test will be valid. Diagnostics, yeah, I mean, obviously, you want to look at other reversible causes of cognitive decline. So, useful to do the bloods, particularly looking at thyroid function, vitamin B12, folic acid, because that can be addressed easily. You need to do an ECG before referring to the memory clinic in case you want to start them on choline esterase inhibitors, which can affect the heart rhythm. Now, more recently, in the last kind of 10 years, there have been a lot of research into genetics, and we mentioned the ApoE epsilon 4 genetic marker, but also biomarkers in cerebral fluids and blood. So cerebral fluids is where you stick a needle into your back and withdraw some fluid from the spinal cord. Very painful, risky, can give you headaches, etc. So it's not routinely recommended as a routine. And there has been some research with biomarkers in blood. So there have been some biomarkers for Alzheimer's disease, but they're more or less used in kind of research rather than in routine clinical practice. Because it has been shown that in cerebral spinal fluid and in blood, the biomarkers appear much earlier than the actual disease. Now, you might ask, oh, why don't we use that to screen for Alzheimer's? The question is twofold. One, would you want to know that you are susceptible to Alzheimer's when there's no cure? And secondly, in volunteer studies, they have actually done that, and they have actually found that only a small portion of people who have these biomarkers do develop dementia, Alzheimer's dementia, during their lifetime. So it's not a very good biomarker. But if you have a patient, for example, with dementia, and you want to know, is it Alzheimer's or is it other types of dementia, these specific Alzheimer's biomarkers can be useful. And obviously in the sense of research. Okay. Radiology, yeah, CT and MRI head. Twofold. One is to distinguish between vascular and non-vascular dementia. And secondly, again, in the circumstance of research with high resolution MRI scans, you can actually detect amyloid plaques and Lewy bodies on high resolution MRI scans. Treatment, very quickly whizzing through it. Cholinesterase inhibitors like donezepil, galantamine, rivastatin, these are the ones which are used in the UK. They have been shown to, or initially they were licensed for mild to moderate dementia in Alzheimer's and Lewy body, but trials have shown that also in severe dementia, people can benefit from them. It's not a cure, but and it doesn't stop progression, but it slows down progression. And as a result, it improves symptom severity, cognition, and activities of daily living and mortality. So I'll be a bit quick because we are kind of running out of time. Yeah, memantine often used for challenging behavior. Challenging behavior is a big kind of problem. So you should avoid benzodiazepines because they can make dementia worse. They can cause falls. They can cause kind of other side effects. And risperidone should only be used in certain circumstances. Vascular dementia, obviously you look at cardiovascular risk factors. There has been a bit of hype recently with newer treatments, which are amyloid beta targeting antibodies, so specific to Alzheimer's disease. And there has been two drugs in Europe, lecanemab and donanemab. So they're both licensed, I think, in the US certainly, and in other countries, also licensed in the UK. So you're allowed to give them in the UK, but they're not approved by NICE. NICE is the authority in the UK which kind of evaluates drugs for cost benefits. And they said that the improvement was only moderate or modest, and the cost is very high. So after 18 months of treatment, and that's the main trials, you had a slowdown of disease progression by 4 to 6 months. Yeah. So only mild Alzheimer's dementia, a modest benefit in mild disease, not being tested in moderate and severe disease, and it's physically correlated with plaque decrease. Downsides, a lot of patients suffer from edema, brain edema, and cerebral hemorrhage. And particularly if you have these genetic predisposition, ApoE epsilon 4, you are at 33 to 41% risk of these edema and bleeding into the brain. If you don't have that risk factor, still 5 to 16%. There are infusions every 2 or 4 weeks, so you have to go into hospital, have it infused. You need frequent MRI scans, high cost of drugs, high cost of infrastructure, and no long-term data on efficacy and side effects. Right. Quickly polypharmacy, and then I'll finish, Ashba. Yeah. Polypharmacy, very important thing in kind of elderly care generally, and particularly amongst dementia patients. So, oops. Definition, if you take more than 5 drugs on your repeats a day, that's called polypharmacy. And there's a high incidence of polypharmacy in patients with dementia. As doctors and GPs, you're very good at prescribing medications, but we are very bad at deep prescribing or taking off medications if they're not needed. And there's a very useful tool, the STOP screening tool of all the patients' potentially inappropriate prescriptions, to help you to deep prescribe. And a study has looked at a large primary care database, and they found that dementia patients are more likely than non-dementia patients to have more than 5 comorbidities, and they are more likely to have polypharmacy with more than 5 or even more than 10 repeat prescriptions. Now, what's the problem with kind of the drug processing in the or metabolism in elderly patients? Elderly patients tend to have a higher increased drug interactions, reduced clearance by the kidneys, in increased liver impairment. Their blood-brain barrier is kind of less effective, so drugs can kind of go from the blood into the brain, and that all can lead to more side effects of medications and increased cognitive decline. Particularly important anticholinergic burden. So with dementia, it's often acetylcholine, which is a neurotransmitter which plays a role. And these treatments for Alzheimer's and Lewy body dementia, donazepam, rivastigmine, they increase the acetylcholine levels in the brain, whereas anticholinergic drugs, particularly amitriptyline and solifenacin, reduce this neurotransmitter. And in elderly, you particularly have psychotropic polypharmacy, so drugs like antidepressants, sedatives, antipsychotics, and these can lead to all these problems, which then result in higher mortality. And when they looked at psychotropic polypharmacy, they found nearly 14%, 15% of older adults with dementia have psychotropic polypharmacy, particularly antidepressants, antiepileptics, antipsychotics, benzodiazepines were kind of involved. Okay, I think in the interest of time, I will leave it. I had something prepared for mental capacity as well, but I think we'll stop it now. Is that okay? Or
I mean, if you want to continue, we've run over time, but if people are interested and want to learn more, we can probably go ahead. How are you feeling, everybody? It's been very informative
We
and it's
still
been
have about 15, 20 minutes because normally sometimes our webinars go on for an hour and a half. You've done
okay.
1 hour.
okay, fine. So yeah, thanks very much for giving me the time. So let's share again. So another thing which probably we in primary care are more kind of involved with is mental capacity. So obviously because of all the problems, cognitive memory in dementia, often you come to a stage where you have to assess or kind of see, does a patient with dementia still have mental capacity to make decisions? Now, first of all, what is mental capacity? So mental capacity or capacity is the everyday ability we possess as a person to make decisions or take actions that influence our lives. Yeah. So I took the decision to kind of agree to do this webinar, and you took the decisions consciously to very kindly join in and attend. Yeah. Now, mental capacity is regulated by a legal framework or mental capacity assessment, I have to say. So there is the European Convention of Human Rights, 1953, and in the UK, that's kind of UK legislation, the Mental Capacity Act, 2005, the Mental Capacity Act, Mental Health Act 2007, and the UN Convention on the Rights of People with Disabilities. Now, what are you looking at? So if we look at assessing mental capacity, basically mental capacity is decision specific. So you might be kind of asked by the district nurse, oh, Dr. Haider, this patient refuses to take his or her medication. Can you assess the mental capacity? So sometimes you get kind of requests, or can you just generally assess mental capacity of the patient? You can't do that. You have to assess the mental capacity regarding a specific question. So you can ask, is the patient able to decide the pros and cons of taking the medication? He might not, but he might still be able to decide if he wants pizza or pasta for dinner. Yeah, so it's kind of very decision specific. So is the person able to make the decision in question, pizza or pasta, at the time it needs to be made? And the precondition for that is there an impairment or disturbance in the function of the person's mind or brain? Usually dementia, learning disability, alcohol abuse disorder, etc., etc. And the third question is the person's inability to make the decision because of that impairment or not? Yeah. So, for example, patient with kind of mild dementia who can usually kind of look after himself gets a urinary tract infection and is completely delirious. So that's a temporary condition, and during that time the patient is impaired, but he it's not that he hasn't got mental capacity because of his dementia, it's because of delirium, UTI superimposed on dementia. Yeah? Now, the guiding principles of mental capacity assessment is that A, you presume every time you see a patient, you presume that he has capacity. That's your baseline. You have to prove that the patient does not have capacity. Yeah? You have to maximize the decision-making capacity. So don't kind of assess capacity in the hustle bustle of the main street. The patient has to be in a calm, quiet environment. You have to give the patient time. He has to have his hearing aid, his visual aids, etc. to make it easy for the patient. Everyone has the freedom to make unwise decisions. So if I make a bad decision, doesn't mean that I don't have mental capacity. I can make a bad decision consciously, and I might not have insight. Tough for me. You always have to decide in the best interest, and that very often comes down to kind of having other colleagues kind of where you can discuss things, so a multidisciplinary decision. And you have to, whatever decision you make, it has to be the least restrictive alternative to use. Yeah? So in Bedfordshire, in Dunstable, where I work, we have this kind of forms where stage 1, we define the issue at large, which needs to be decided. Stage 2, we look at the diagnosis, the level and the nature of impairment. Stage 3, we consult relatives, friends, next of kin, or if you feel that the next of kin hasn't got the best interest, or if there's no next of kin, you have to initiate or find an independent mental capacity advocate, and their pathways how to allocate a IMCA, an independent mental capacity advocate, basically an advocate for the patient with dementia. And then finally, stage 4, you don't make the decision on your own. Often, if it's big decisions like care home admission, big operation, life-changing treatment, you have a multidisciplinary team, and then you make the best interest decision, the decision in the best interest of the patient. You know? So kind of quickly going through that, two-stage test. First, the diagnostic test. Does the patient have an underlying condition? Yes, no. So dementia, learning disability, whatever, alcohol disuse, and is the condition long-term, permanent, or is the condition temporary? So sometimes you might have to do a mental capacity assessment in a patient with severe depression who wants to self-harm, section him, etc. But that decision will be just limited for a period of time. And then you do a functional test. So is the patient, and that's 4 parts, is the patient able to understand information relevant to the decision? Secondly, is the patient able to retain the information for long enough? Thirdly, is he or she able to weigh the information? And fourthly, is the patient able to communicate the decision by any means? Now, the fourth point is usually the point where a lot of people they're able to talk and kind of communicate, but it's all muddled. So if any one of the 4 points, understanding, retaining, weighing, communicating the decision, is impaired, then they lose mental capacity. Okay. Right, lasting power of attorney, very quickly. So what is lasting power of attorney? So you might kind of want to be proactive and think ahead. So what will happen if I actually lose mental capacity when I'm 95 or 98? Who will make decisions for me? So everyone, and again, that's for the UK. I'm sure there are other ways in other European countries and the US. Any individual aged 18 or above who has the capacity to appoint an attorney can appoint an attorney for health and welfare, and also for finance and property, to make decisions on your behalf once you lose capacity. I'm the donor giving the appointment to my attorney, and I can appoint 1 or more attorneys, and they can act jointly or separately. There is a process to that, so you have to kind of complete a form. The form has to be completed by either or signed and witnessed by either a doctor, a solicitor, and it has to be submitted to the Office of Public Guardian. And the Office of Public Guardian has a register, and in case it's needed, the healthcare professionals in A&E or in the GP practice can search the register and then ask the attorney. But two preconditions: one, the patient himself or herself has to have no mental capacity at that stage, and B, the LPA needs to be registered. And still, you need to act in the donor's best interest. So if you think a relative has a LPA for finances and just rips off the patient, that's a case of adult safeguarding, and you are exempt from following the LPA. In fact, you have the duty to kind of report that. Yeah? And oops, quickly, court of protection. So if there's any disputes, or if the Mental Capacity Act needs to be implemented, you have to go through the court of protection, and the court of protection rules on disputes, and it can also appoint deputies to substitute attorneys and decision makers. I have mentioned the independent mental capacity advocates for people who don't have next of kin. All these things are kind of listed in the BMA Ethics Toolkit for Mental Capacity Act. Very, very useful booklet which you can download online. Another quick thing would be advanced decision to refuse treatment. That's, again, I mean, often as a GP, I'm asked by patients in their whatever 50s, 60s, 70s, who are well in themselves, who have mental capacity: doctor, can you issue a DNAR form for me? DNAR is do not attempt resuscitation. So in case I die, I don't want to be resuscitated. Now that's a medical kind of decision made by the healthcare team, often for people who are end of life, be it due to dementia, be it due to advanced cancer, etc. And it basically weighs up the distress of jumping onto a person's chest with the chance of a successful resuscitation. And if someone is 95, has metastatic cancer and dementia, probably the chance of bringing the person back is very, very little. And it's not a good use of resources to call out the ambulance and resuscitate that patient, but let the patient go. So that's a kind of decision which often medical teams do. You as a patient for yourself can make an advanced decision. So if I, as a person, don't want to be resuscitated in the future, I can, whilst I have mental capacity, make an advanced decision to refuse treatment. It's a decision to refuse specific treatment. So you might have come across people from the Jehovah's Witness community who refuse to take blood transfusions. So often you will see they have done a written advanced decision to refuse blood transfusions in any kind of circumstances. You can't make an advanced decision to have treatment, so you can't say, I want to have chemotherapy or I want to have this and that operation when I get ill. You can only refuse treatment. Yeah. Right, I think that's it so far with regards to my slides. Resources for patients, and these are the references. So thank you everyone again for listening, and sorry for running. And again, thanks for Dr. Shabi and IMI for giving me the chance, and also thanks for IMI, particularly UK and Germany, Austria, for the support and companionship. So any questions?
Thank you, Dr. Aijaz. It's been brilliant. It's been amazing. Very, very, very informative and very fascinating presentation that you just gave. I mean, everything that we've kind of spoke about, I think the brilliant point was when you quoted from Quran, knowing nothing after having knowledge. That's a brilliant description of dementia, I guess. So we've been getting some questions in the chat, and I think most of them you've answered during the presentation, but I'm just going to run through them. There was one regarding the causes of dementia, but I think they particularly wanted to ask in sort of earlier age group, like 15 or 15 years in teenagers. So anything specific you want to talk about?
So I think early onset dementia, there are two types, isn't it? So there's early onset dementia in Alzheimer's disease, and then there's frontotemporal dementia, which also
Hmm.
affects more younger people. So again, I'm not sure if there's any, I think there's some kind of increased genetic susceptibility in early onset Alzheimer's disease. Um, and kind of for frontotemporal disease, again, I'm not an expert, so I haven't found any particular reason, but I think it comes down very often to genetic predisposition, obviously modifiable risk factors. So I suppose in the next 50 years, we will see a steep increase in younger age dementia because of all the problems with air pollution, etc., etc. But these things are very multifactorial, isn't it? So it's basically very often you are the unlucky one
Hmm.
kind of being affected. Yeah.
Yeah, I mean, and there've been questions regarding new drugs on horizon and research around the cure of dementia, which I think you've answered during the
So
talk.
again, no cure, um, but kind of slowing down of the progression. So for Alzheimer's specific, these amyloid beta antibodies, so they are very, very expensive at the moment. And I think in the UK, I suppose you can have them privately if you see a private consultant, but you have to pay for it. At some point, certainly prices will come down and then NICE might kind of reassess it. Very interestingly, I found these weight loss injections. So there's a lot of interest in research in how these weight loss injections, Mounjaro, Wegovy, tirzepatide, etc., can modulate the risk of dementia. And I think there is probably a lot of information coming down the pipeline on that. So there are trials going.
Yeah, I
Yeah.
mean, it was very interesting to learn that SGL2 and DPP4 inhibitors and GLP-1 agonists, they play a role. I think as you were describing during the presentation, the modifiable risk factors in diabetes and health condition, cardiovascular risk factors being one of them. I think this is a new excellent development for the future of NHS, I'd say, and for the dementia people as well, dementia patients.
And
Okay,
particularly, I mean, these DPP4s and SGLT2s, so dapagliflozin, sitagliptin, etc. It's in addition to controlling the diabetes, the beneficial effects. And again, these drugs are going to become cheaper, but I think they have only been evaluated in the context of diabetes, not separately from diabetes. Whereas SGLT2s have been shown to be probably effective even if you're not diabetic or obese.
that's really interesting. Okay, moving on quickly. I think there was another question regarding if dementia has completely taken place and now you've been diagnosed with dementia, how can we delay the progression of it? Is there any steps or
So
anything that done?
again, yeah, these kind of studies have shown that even at a later stage, if you modify some of the modifiable risk factors, so stop smoking, reduce improve your diabetes control, your blood pressure control, lose weight. So even if you're diagnosed with dementia and manage to lose a modest amount of weight, you're able to slow down the process. And then there are obviously the current mainstay medications, donazepam, galantamine, rivastigmine. They have been shown to slow down the progression, um, but they don't unfortunately stop the progression of dementia. Yeah.
Certainly. Hi, and there was one question from another GP colleague, Dr. Faria, asking about alternative tests for people who can't speak English and sometimes when GPCOG is, when you really struggle to get the GPCOG answers. So any alternative test that they could do, like the drawing stuff
Uh,
and.
that's a good question. I mean, I often had kind of patients like this who came with a translator, which is often a difficult kind of scenario because obviously you want the direct kind of response from the patient, isn't it? So to give you a simple example, I usually use the 6-item cognitive impairment test, which asks, what year is it? What month do you have? I'll give you the following address to memorize and then ask you again, what hour, what time is it? Count back from 20 to 1, tell me the names of the months from December downwards to January, and then repeat the address phrase. So it's kind of a lot of verbal kind of things. And yes, you can use a translator, which kind of makes it a bit so you have another person in between, or you use Google Translate. I mean, I think there is, I'm not aware of, and these are all screening tests, but screening tests are screening tests. So you also have to look at the whole clinical picture when you diagnose. So sometimes patient with dementia might have a good day. They might actually perform quite well on the screening test. But if you look at the whole picture, the inability to kind of do daily activities, uh, walking on the streets some days. So when diagnosing, you kind of take the whole picture into account. And obviously diagnosis is often not done by general practitioners, but kind of in a more specialized memory clinic setting. And I mentioned kind of biomarkers. Biomarkers as such are not diagnostic, but they help distinguishing between Alzheimer's and non-Alzheimer's. I mean, sometimes you have a patient who is admitted to A&E with a head injury, and when they do a CT scan, it shows kind of severe small vessel disease or atrophy of the frontal areas of the brain, and the patient might not have any symptoms of dementia, but if they had dementia, that would kind of correlate with the findings, isn't it? So, yeah, I think language barrier is a bit of a problem. Mind you, there's a lot of information on Alzheimer's Society and Dementia UK websites in other languages to kind of explain things.
Yeah, that's brilliant. There's another question regarding advanced care planning, which you just briefly touched on, and DNR forms. And I think I'm just going to try and summarize the question. So what they've been trying to ask is that generally in UK there's a culture like people diagnosed with dementia. If we do the advanced care planning, we're kind of making sure they've got DNR. If they end up going to the nursing home or the care homes, there's like an end of life pathway or a palliative care site. The road is taken for them. Whilst in contrast to our sort of native countries, there's like an element of over treating people who are dying, and there's no respect about dignity of the patient in advanced care planning. So they've given their opinion with this thing that moderation is the best thing to adopt in this sort of situation. Any sort of
No, I think that's a very, very good question and very interesting. I would actually like to open that up maybe to everyone. So yeah, I mean, I have seen that very often if you talk to a Caucasian patient or a patient who kind of grew up in this society, there is often a better acceptance of dying, letting go, than compared to our society, in spite of the fact that we actually spiritually have a much better connection to the afterlife. We have so many hadith examples from our Ahl al-Bayt. I mean, just mentioned Karbala, ne? Where this world is not as important as the other world. And then often I would like to hear from everyone. I personally often see the resistance from family. Obviously, they love their mom, dad, whoever is, rather than the patients themselves. The patients themselves often are kind of, I want to go in peace, but often it's the relative, oh no, he's not eating, send him to a hospital, put up an IV drip, put up an NG tube. And if these things are kind of appropriate or just a torture and prolong the distress. So I think probably in our communities, in our masajid, with our ulama, there needs to be we need to talk about these things much, much more than we actually do. Yeah. It might be
absolutely.
also a first and second generation thing, isn't it? We have just come into our countries, into these countries, and we're just kind of developing our society, getting settled, getting our children settled. I don't know what the situation in India, Pakistan, Iraq, Egypt is, if there's different approaches to dying and death. Yeah.
Yeah, no, that's definitely. I think you've highlighted a very interesting point here about the spiritual element, and maybe the ethical value as well. It's the relatives mostly who probably are more concerned about their loved one, and obviously it's never easy to let go. But yeah, I mean, we need to see what the outcome and the outcome is going to be for the patient or for the person who's going through this. All again, a personal opinion, but yeah, open to anybody who would want to come on this.
Can I comment?
Yes, please.
Okay, I'm Dr. Bukhari. Thank you very much, Dr. Aijaz, Haider. very comprehensive and very informative. Especially, I was thinking the different things I was applying on myself because my age is about 65 and I'm going in the aging state. One of my question is you have described well all of the risk factors, but can you correlate? Can you tell about the diet? Because in Alzheimer disease, certain peoples correlate with the pork proteins. These makes more early bodies in the brain. Is there any correlation with this such type of diet and the dementia?
Yeah, so
This is one
yeah,
question.
so
Second
yeah,
question.
sorry, carry on.
Yeah, yeah. Yeah. Okay. Okay. Second question is the regarding the different risk factors. You know, during the COVID time and after the post-COVID time, a terminology was used that was the mental fog, brain fog. That is, I think, in my experience in Pakistan, I have seen so many people were suffering with post-COVID, and they were diagnosed as a brain fog, and after that they are now recovered, but they are suffering with dementia. Is there any correlation in your observation?
Yeah, no, very, very kind of useful question. So the Lancet Commission on Dementia has actually looked at diet as well. So they didn't find any significant correlation, but they found a mild kind of correlation with like a positive correlation in preventing or reducing the risk with a healthy diet and Mediterranean diet. They did not find an
With the pork diet, pork
pork
proteins.
protein. There wasn't anything I could find on pork specifically. They also looked at different things like processed foods, multivitamins, cocoa flavonoids, berry antioxidants, and all these things were not associated with either an improvement or deterioration. I couldn't find anything on pork specifically. Yeah. COVID, yeah, and generally kind of chronic fatigue, long COVID, often it can give you brain fog. If it increases the risk of dementia as such or not, it's a difficult question. So again, I don't think specifically for COVID there's probably kind of there might be studies coming out in the longer term, years and years, but I don't think there's any data at the moment. But I think there's a difference between dementia and concentration. So these conditions that you get, chronic fatigue syndrome, fibromyalgia, depression, where you get kind of brain fog, that's more where your concentration is affected rather than having a correlate or a physical correlate in dementia. Now, they have found in large studies that depression, where concentration problems can be a symptom, is associated with a higher risk of dementia, but I haven't found anything in the sense of fibromyalgia or chronic fatigue. They did have a look at chronic inflammation, so episodes of sepsis,
Yes.
pneumonia, cellulitis, and again, there wasn't any correlation on the risk of dementia for these things. Yeah.
Thank you. Thank you so much.
Yep, that was brilliantly explained. I think yes, brain fog is slightly different to maybe what dementia is. And I think mental health conditions like, as you've mentioned in this in the presentation as well, like depression and anxiety, which could be risk factors, can also give you like sort of brain fog and concentration issues, which could further lead to, these sort of issues in sort of future, but there's no obvious correlation in the current studies. Okay, all right. Last question that I've got in the chat, and then after that, I'll open the floor to people on present here. So there's been a question about GLP-1 agonist data. Data shows increased risk of depression and suicidal thoughts. Long-term use could increase dementia.
So that's kind of a new thing for me. So probably I would say is watch the space. So obviously these kind of medications are probably relatively new. I mean, even if you look at it in the context of diabetes and obesity, whereas with kind of dementia, cognitive impairment, you look at decades of kind of the trajectory. So yeah, I'm afraid I can't give you a direct answer on that, but yeah, watch the space. Yeah.
Absolutely. Anybody, any other further questions you have? You might want to unmute yourself and ask Dr. Haider. Somebody's saying, following Dr. Saab's question.
Shri, can I ask you a question? So a lot of people you see in UK, particularly in the tubes and buses, playing with crossword puzzle and Scooby, etc. Does that help?
Oh yeah, I think any type of cognitive stimulation, be it crosswords, be it puzzles, be it simply reading books or simply kind of conversations. I mean, that comes down to social isolation, isn't it? Why are patients who are socially isolated at higher risk of kind of dementia? I mean, if you're socially isolated, you can still probably do crosswords, but that kind of visual hearing input, that interaction with people. I mean, if you look at group interactions with other people, that's a very complex thing for your brain to do. But I think, yeah, crosswords, any type of cognitive stimulation is definitely a positive and preventative thing. And as I said, start early. Yeah, start in your adolescent or encourage your kids to do that and continue with that. Yeah. Interesting point, actually, the epidemic of mobile phones, social media, which really kind of affects the ability to communicate, input, output, etc. Will that have an impact? Interesting question. I don't know.
Yeah, absolutely. That leads on to the next question that's been asked by Sajjad Haider in the chat, which says, obviously in terms of progression and prevalence of dementia, has it been affected by the long COVID, like post-COVID effects? Has there been like any sort of researches that you might be aware of, or any sort of neurological impact that it may have? Again,
yeah, so I think COVID itself had an impact on the social isolation level. Yeah. Probably also an impact on the level of people for, well, a number of years having less opportunity to kind of follow their exercise regime, whatever, the diet kind of got worse. So on that level as well, if long COVID itself has a long-term effect on the incidence or prevalence of dementia, probably we'll have to wait a few years to kind of make that assessment. I mean, I know there's a lot of research on long COVID ongoing, and there are probably kind of large cohort studies following up long COVID patients over years and decades. So I think we will hopefully get some answers back in a few years. Yeah.
yeah.
Dr. Aijaz, I will send you the study done in Pakistan, and I was the part of the study on the brain fog. I think that study will be more helpful in the people. No doubt, the COVID, after the post-COVID and long COVID, and fog is one of the main factor for future dementia, because no doubt otherwise, in other words, isolation, but they have affected the brain, blood vessels and other things that will affect. No doubt it will take time to prove that the long COVID and the brain fog is one of the important factor of the dementia. And again, in our urban pathology, that is written that the four proteins are responsible for creating the antibody. That is a protein that causes Alzheimer's disease. That is why I was asking, because as a basic teacher of pathology, I have read this thing that is very, very important. The four proteins are related with the one type of the dementia that is called the Alzheimer's disease. Thank you so much.
No, thank you for this information and the insights. That's very kind of interesting. Yeah, yeah.
Absolutely. Any more questions from anybody?
Assalamualaikum. I think you missed a few of my questions, Ashba.
Sorry, who's this?
Medina.
Medina. Okay, do you want to ask
Thank you for
Medina?
your
Sorry.
presentation. I just had a couple of thoughts. Recently, I think it was January or February, there was an article published in Nature or Nature Medicine, and it highlights that there's a higher rate or higher microplastics in dementia patients, but it was they did samples basically. So have you come across that, or?
I think I came across, I just whizzed through the abstract of that one. So they, as I understand correctly, they did kind of sections or microscopic kind of examinations of brain samples, and they found that some microplastic transverses the blood-brain barrier and causes kind of chronic inflammation. I think it's an excellent point and a very important kind of feature of human impacts on an environment, microplastic pollution, and it's, I think, particularly nanoplastics, which are even smaller, so they can traverse the blood vessels. I have to kind of look it up again, so I don't remember from the top of my head if there was an exact association on dementia itself, or if it's kind of projected to be a risk factor. But there's certainly kind of evidence that nanoplastic and microplastic can accumulate in brain tissue. Yeah.
Okay, thank you.
Absolutely interesting to know that. Yeah. So, any further questions? I'll allow like a couple of more minutes, and then probably. I think there was a very like an interesting point that you made during the presentation, which I really liked, which is about the social isolation and how we as a community can help our elderly population. As Masajid community centres, you know, there could be loads that we can organise for not just for the older population, but for, you know, just people to get involved, so that we don't get to that stage where we are kind of feeling isolated in elderly life, which is more common in, you know, people from the Western world, people, you know, obviously from other ethnicities, not so commonly with our sort of, you know, ethnic groups. But absolutely a very, very interesting point, and something that we can take as a take back home message as a community, something that we can really work on from our community, from our like platforms. Even as an IMI, I think that would be something to look into and maybe develop further.
Absolutely. I think it's so important at different levels, isn't it? The cohesion of the community, kind of interaction between older members, but also older members and younger members. Yeah.
Absolutely. Okay, I think that's it. Haven't been getting any further questions, but Dr. Aijaz, it's been amazing. It was very, very informative and absolutely fascinating. All of the details that you've provided have been evidence-based, and it's been really brilliant and amazing. Thank you very much.
I'll say thank you, and it was good fun. I enjoyed it, the preparation and the session, and I would encourage everyone who has been part to kind of think about the topic and come forward.
Just before we go, one last point that I would like to make is we are planning a few more sort of educational webinar, as I mentioned earlier. This is first of our web series. We'll be doing more every month. We'll be focusing next month as Ramadan is approaching, so we'll be focusing about diabetes, management of diabetes in Ramadan. So we will have some diabetologists, experienced diabetologists, who would be giving their opinions. So if you have any questions, you can start jotting them now from now onwards and watch this space. Secondly, we have a IMI UK Manchester event coming up, which we are probably planning around April time. So continue to watch this space and keep your availability for us, and then we can hopefully see each other in person.
Thank you so much. On behalf of Sadiq Virtual University, could I thank you, Aijaz? Where have you been hiding? I've met you so many times. I mean, so much information you gave. There should have been 3 webinars out of this material. It's so fantastic. And it goes without saying, it's been wonderful. Sakina had to leave because she had to go somewhere. She asked me to announce 2 things. A, that we have next week, we have a webinar on AI and the use of digital technology in modern medicine. That's next coming Saturday. And then on 22nd of February, save the date, it's 5th anniversary of Sadiq Virtual University. So we are celebrating with a high-powered symposium. I think there are 8 powerful scholars from different countries who will be talking about various fields in medical education and medical sciences. So mark the date, save the date in your calendar, 22nd of February. It'll be announced, of course. And if there is anything else, do you want to conclude the session, Ashba? Over to you. You want to conclude it, and then I'll stop the recording.
Yes, please, we can stop the recording now.
Thank you.